I hope the system works. So this is just to show you that I really like informing patients, not only to you, but also in Holland. So we have our patient day each year, which was not provided during the COVID, of course. But so in 2024, we started again with this patient day. And as you can see here, we not only have lectures on migraine, but you can see also here in the middle one of our lab persons where we provide the possibility to our patients to collect the DNA from themselves, because we do a lot of genetic research, as you might know. And here you can see how you can make a necklace of your own DNA. So that's really fun. And also you can see here on the right that we also have a national podcast on headache. And Annemiek Lely is one of the persons with whom I do my podcast recordings. So let's talk about migraine. And I think you might all know that migraine is often more occurring in females than in males. So there are 3 times more women who suffer from migraine than men, and 1 of 3 women will suffer from migraine during lifetime. And as you can see also here, it's on the right side, it's especially when people are young, between the age of 20 and 50, there is a peak incidence of migraine, and with that it's a high burden not only for patients themselves, but also for their families and also for the environment. This is just a short picture to show you a group of girls, and this is a picture that was taken when my daughter was turned 15. And I realized when I took this picture at that time that 1 of 3 of these girls will develop migraine during lifetime. And I did not know at that time that 1 of those girls would be my daughter. I'm not sure whether I can show her here, but she's the one with the colored skin with her girlfriend. She's the left one. And she was then 15 and she had no migraine at all, but she developed migraine later on during life. So the burden of disease of migraine is immense, and I will not get into detail on all this information that's on this slide, but I want to point especially that I was really impressed by the fact that 38% of people with migraine indicate that their migraines affect their parenting, and even 3% of them decide not to have children, which I think is quite impressive. And also 30% of patients indicate that migraine affects their career, and 22% are worried about losing their job. And also almost 50% of patients with migraine indicate that they think they would be better partners without their migraines. So besides the cost of the migraine itself, I think it's an emotional burden for patients, but also for their work and relationships. So the question is, why do you get a migraine attack? And this is just a schematic view of how I try to explain this to my patients. So we have the impression that the threshold to get an attack is quite low, in migraine patients compared to a healthy control. So, and this intrinsic threshold to get an attack is determined most and importantly by genetic factors. So when your father or mother or other relatives in the family suffer from migraine, it's more likely that the children will get migraine as well. So if I talk about my daughter having migraine, you can imagine that it must come from someone, and that someone is me. So I'm always, as I say, in the happy denial of my migraine, because I think my migraine attacks are not so severe, and I didn't recognize them previously. But the fact that I have migraine makes it more likely that my children will suffer from migraines, and they will suffer from migraines at a younger age, and they more likely will have migraine with aura. So we did some family research on that, and this is what we found. So genetic factors are the most important factor why your threshold for migraine is lowered. But genetic factors are stable, so it doesn't explain why you have an attack at a certain point in your life, or at a certain point in your month or week, and at the other days in a month you don't have attacks. And this threshold is thus fluctuating. And one of the factors that is most importantly to lower down your threshold is, for instance, the menstrual period, as is indicated on the line below. But even then, even if you have this fluctuation of your threshold due to menstrual factors, there must be other factors as well. And this is indicated here. So to reach this threshold and to go over it and get a migraine attack, there are other factors involved. And for one of them is, for instance, sleep deprivation seems to be a provoking factor for most migraine patients, but also, for instance, drinking wine, especially red wine, is mentioned by many patients. So the combination of sleep deprivation and drinking wine, and maybe also a lower threshold due to the menstruation, makes you go over this threshold. And this explains why at certain periods in a month you don't have your attacks, and at other periods in a month you do have your migraine attacks. And the hypothesis is that using the contraceptive pill might make your vulnerability to go over this threshold less likely. And I will come to that later. To explain a bit more about the genetics, and this is a complex picture just showing that in 2010 we found one locus, meaning it's a position on the genetic DNA where we think the gene must be involved in migraine. In 2010, we found one locus, but the more people you include in this type of research, and you can see this is over 100,000 migraine patients included, and also almost 1 million of controls. And nowadays, we already know that 123 loci, meaning places on the DNA, are involved in migraine. And this actually means that there's no use of doing a genetic test at this moment in a migraine patient per se. What you need to know is that you're probably genetically prone to get a migraine attack, and with that you transmit all these genetic factors also to your children, and with that they will also be more prone to get migraine attacks. So genetics is very important, and I think the most important factor why you have your migraine attacks. But there are, of course, also other triggers. And as you can see here, we did a lot of research. This is all cross-sectional research, where we ask patients, what do you think is important in triggering your attacks? And as you can see on the left, it's especially the hormones are mentioned, and I will come to that later. But also stress, sleep deprivation, jet lag, going to the mountains, weather changes, alcohol and bright light are often mentioned as triggers for migraine attacks. So it's probably a complex factor of all these triggers that makes you more prone at a certain point to get your attacks. And currently we are doing studies to investigate this more on an individual level, asking patients to fill out our headache diary, and I will come to that later, but also fill out specific triggers to look whether we can use artificial intelligence tools to predict the attacks on an individual level. But I can already explain to you this is really tough work and really difficult to do. So here you see again a picture of my daughter. She's now in the middle below, and this is just to explain to you that when she turned 18, she went to study in Leiden, and she wanted to study medicine, but she was not selected, so she started with biology, and she said to me, I'm going to start biology. I don't like to study that much, and I want to live my student life as well, so I'm going to live in Leiden. I'm going to go to I think you call it a sorority or fraternity club, and you cannot stop me. And I said to her, this is the terrible thing to do, because you will likely have sleep deprivation, you will drink alcohol. As you can see here, it's a bit of a scene, placed in scene, of course, but so I said, you are going to drink alcohol, you have sleep deprivation, this is not good for your migraine, but you have to do it because I think social life is extremely important. At the same time, when she also kept a diary, and we, with keeping this diary, actually saw that the triggering of her migraine attack was not at all related to this student life. So the most important trigger also in my daughter, but for many women, is still the menstruation period. And this is what you can see here. So during the menstruation period, there is a peak incidence of your migraine attack as indicated in yellow. And it's already indicated here, but I will explain to you a bit further. This is especially true for the migraine without aura attacks and not as much for the migraine with aura attacks. So first we ask, again, in our cross-sectional questionnaire in our migraine patients, whether menstruation was a trigger factor. And as you can see here, almost 80% of the females reported migraine to be a trigger for their migraine attacks. Why is this important? Because during this menstruation period, it might be that the use of acute medication is less successful. And this is shown here. So what you can see here is it's indicated here in the dotted line, your migraine attack. And in the green part of the left part of this slide, you can see that there is a moment where you take your triptan or D10 or whatever acute medication. So there is a window of opportunity where you can treat your migraine and you hope it will resolve and will not come back. But many women especially experience what we call a recurrence. So the attack recurs, and mostly it's within the next day. So the next morning they wake up again and they have there is a recurrence of the migraine attack. And these women have to re-intake a second triptan. And this is what we call a recurrence. And we've looked into the data of all the triptan use, which was published previously with all the clinical trials. And we actually noticed that women had a similar headache response to the triptans as men. Women reported more side effects due to their lower body mass index, but at the same time, women had more recurrences. So we were wondering whether these recurrences was due to the longer duration of the menstrual-related attacks. So we did a study on that, and for this study, we used our headache diary, and this is an e-diary. It's an application. It's not a free available application. It's an application that we can only start from our hospital, and we use this not only for scientific research, but also for our clinical practice. And as you can see here on the left, when people are referred to our neurology department, they are asked to download this application. They fill out a screening questionnaire. Automatically, an algorithm is calculating whether it's likely that this patient will suffer from migraine or not. And if so, the patient receives an extended migraine questionnaire that they fill out. Again, an automatic algorithm calculates whether it's likely of migraine. And then the patient journey application starts with a daily headache e-diary, which patients fill in on a daily basis. And as you can see here, you can see what you filled out on your iPhone or other mobile device, but it's also transmitted at the same time real life at our headache clinic, and so this is integrated in our patient files. So we can also follow up our patients, what's called telemonitoring. And here you can see the example of a month of this type of diary, and without explaining you the full all the details that are in this diary, you can see a month is indicated as 28 days, and you can see also the dates on the right, on the above line. And also you can see that red is not good, so the red dots are the migraine attacks. So immediately you can see this patient had 4 migraine attacks. The blue indicates whether there was intake of acute medication, and we make a difference between whether they took normal painkillers or NSAIDs or whether they took triptans. And we indicated just some of the comorbid features that are with the migraine attacks, namely nausea, vomiting, photo, and photophobia. There are a lot of other questions that we have in this diary, but we thought with our patient that this is the most important information. Also, you can see on the bottom in purple the change of prophylactic medication, so we can actually see what type of medication people take. And most importantly, you see the menstrual bleeding. So using this for scientific purposes, we also acknowledged with our patient that it was extremely important to show also in clinical practice. So what are menstrual migraine attacks? Menstrual migraine attacks are those attacks of migraine that occur with -2 days prior to the first day of menstruation up to 3 days of the menstruation. This is called a menstrual migraine attack. And when you have 2 out of 3 months of these menstrual migraine attacks, you are diagnosed with menstrual migraine. So a menstrual migraine are migraine attacks occurring in the perimenstrual window in 2 out of 3 consecutive menstrual cycles. That's the definition of menstrual migraine. There's also a definition of pure menstrual migraine where women only have these menstrual attacks and no other attacks outside of this window. But we've noticed in our diary studies in more than 500 or 1,000 women that pure menstrual migraine is quite rare and that most women also experience some attacks outside of this menstrual window. So then we looked actually whether there was a peak incidence of the migraine. And as you can see here, we looked at the prevalence of menstrual migraine in patients, whether they have a natural menstrual cycle, but we also took into account those women who took hormonal contraceptive, but we had a stop week of 1 week. And as depicted here, you can see indeed a peak in the incidence of migraine attacks during this natural menstrual cycle, during the menstrual period, or whether people or women had this stop week of hormonal contraceptives. Most intriguingly, in those patients who suffer from migraine with aura, we looked at whether there was a peak incidence both of the migraine attacks without aura and the migraine attacks with aura. And as you can see on the right, you can only see a peak of the migraine attacks without aura. So migraine with aura attacks, they have a different response to hormonal changes than those of without aura, even in a patient who have both types of attacks. What we also notice that this perimenstrual attack duration is longer, as is indicated here. So this is an example of one of the women, but we did a statistical analysis on a large group of women. And as you can see here, that also in this woman, the attacks that are outside of the menstrual window are short-lasting, and also you can mostly see that the acute medication is effective and there's no recurrence of attacks, whereas in this perimenstrual window you can see that this woman needed took a triptan. It was effective, and the next day she had to take another one, and the third day she had a less severe migraine day, so she didn't take any medication, but she had 3 days of migraine, whereas during the attacks outside of this menstrual window, she had short-lasting attacks. So indeed, these perimenstrual attacks are of longer duration. And with that, women are more prone to chronic migraine and medication overuse headache. And so this is a biological explanation why women are in need of more intake of medication and thus are more at risk to have medication overuse headache and chronic migraine. So it's not a gender issue, it's a sex-specific issue. And I think that's really important to stress, especially as most prescribers of this kind of medication are still males, and they are totally unaware of this phenomenon. So when you have a migraine woman and she comes back to your office and she says, well, I'm in much of need of re-intake of the medication, many doctors are labeling patients as having a behavior problem and with the re-intake of medication, whereas they should be aware that it's a biological phenomenon related to the menstrual period. So not only hormones influence the migraine threshold during the menstruation, but also during pregnancy in the perimenopausal phase. So during pregnancy, we know that migraine with aura especially drops, and the incidence of the migraine attacks drops, whereas migraine with aura, which indicated in purple, increases sometimes, or even migraine with aura attacks may occur for the first time during pregnancy. In the perimenopausal phase, there's a lot of fluctuation of hormones, and then you can also see that there is totally deterioration of the migraine without aura attacks, whereas the migraine with aura attacks seem to be more stable. And this is likely due to hormonal fluctuations. So during the menstruation periods, you can see it on the left, we think there is a drop in both estradiol and progesterone prior to the menstruation. And with this drop, it might provoke the attacks. Whereas during pregnancy, there is an increase of estradiol and progesterone. And with that, there is a protection against migraine attacks. And in the perimenopausal phase, there is a decline, but also a lot of fluctuations, especially in this period where you're not in the menopause. So you still have your menstrual periods, but these menstrual periods are sometimes shorter or longer, so they're fluctuating. And with that, this is an indication of a fluctuation of these sex hormonal levels. And with that, that's a provoking factor for attacks, we think. So the most strong theory about the provocation of migraine attacks is that we think it's that the migraine can be triggered by the withdrawal of estrogen following a period of sustained exposure. But if you look at the proof of this kind of studies, it's really, really very small. So in the 70s already Sommerfeld did some studies, but it was only in 5 or 6 patients. And McGregor, that you probably all know of, also performed a study in 2006, and Pavlovich also did a study in 2016, but it was not very specified for migraine, but it was about headache. So because we thought that the proof for this estrogen withdrawal theory was quite loose, we performed a new study which indicated here, and we call it the WAT hormone measurement study. And in this study, we included 31 migraine patients and 18 healthy control subjects. And we asked them to come to our hospitals for 2 months, as you can see here. One period during the ovulation on 3 days of the ovulation, and also in the process thereafter towards to the menstruation period. And you can imagine that this is a really extensive study. These women, they had to come to the hospital in the morning to get the blood drawn from them. And we measured in the serum, we measured all sex hormone levels. And we have currently submitted our paper to a journal, and we hope it will be published soon. And next time I will be able to tell you whether it is actually confirmed our hypothesis on whether the estrogen drop prior to the menstruation is an important provoking factor for the menstruation period and for the migraine attacks. In the meantime, you and I still have the question, if there is a sex hormonal changes and it's likely that it's the decline prior to the menstruation, how can we already start with hormonal treatment? And many doctors already provide this kind of hormonal treatments, which are indicated here. So I see that a lot of estrogen is provided with gel, patches, or only estrogen suppletion. Progesterone suppletion is being provided by for many women by doctors, but also combined oral contraceptive are prescribed. In the meantime, you should be aware that the studies that have been performed are not strong. So they only used small sample sizes for this kind of studies. There's no clear proof. No control groups were included, and if you provide progesterone only, there are still fluctuations in the estrogen possible, and we think especially that these estrogen fluctuations are provocative for the migraine attacks. So because this proof is so minor, we also decided to do a trial on this. And this trial is running now for, I think, 3 or 4 years. We hope to finish this at the end of the year. And in this study, the WAT trial, we include women with a diagnosis of menstrual migraine. And we have a separate group of those women with perimenopausal migraine. And we ask the patients to fill out this e-diary for at least a month, and then they are randomized either for the continuous use of the oral contraceptive pill or vitamin E. And vitamin E is used as an active comparator. So we didn't want to choose a placebo because it's an open study, because you cannot blind the use of oral contraceptive pill. And there is this very small study suggesting that vitamin E would work on the endometrium, and with that might be of influence for the migraine attacks. So we're including now young women with menstrual migraine, and we also included the elderly women with perimenopausal migraine. I can tell you that this study is really tough to perform, and there's only one main reason why it's tough to perform. The most important reason is that many women already go to a doctor or gynecologist or general practitioner and ask for hormonal treatments. So they're already using it without any proof. And with that, we cannot include them anymore for the study. The second reason why it's really difficult to include women is that many young women, especially in Holland, are on TikTok. And there is a huge debate on the use of hormonal treatments in general. They're talking about natural birth control. There is a huge negative idea about the use of oral contraceptive pill. So many young women are really reluctant to use this type of medication. Whereas their mothers, who are in the perimenopausal period, they are very eager actually to use hormonal treatments, but they're talking about bioidentical hormonal treatment. So they're already being to the gynecologist and they're already on treatment. So that's why it's really difficult for us to include patients who are still willing to investigate this with us. Why do I think it's important to investigate it? Because there is also a risk of using hormonals in women in general, but also in migraine. And one of the risks are breast cancer. That's one of the risks, so we should be careful with that. So the recommendation is for perimenopausal women to treat for maximum of 5 years, but also the cardiovascular risk and the use of oral contraceptives. Although the modern oral contraceptives have a lower dosage of estrogens and are much safer than the older formulations that have been used. Why is this important? Because there is a migraine-stroke relationship, as you might know. So we know that migraine in general is a stroke risk factor, and it's indicated here. You can see that for migraine without aura, it's not that high. The relative risk is not that increased. But if you look at migraine with aura patients, the increase is 2 times. And if young women below the age of 50 have aura and they also smoke, it's increased to 10. If they use the oral contraceptive, it's increased to 15. And if a young woman with aura who smokes and uses the oral contraceptive, the relative risk is increased with 34 times. So taking this kind of medication is not without any risk. And that's why for the WAT study, we didn't include those women with migraine with aura. Also, we showed in Holland, but also in other countries, that women with migraine have more risk for cerebellar lesions. We think it's a vascular problem, and also white matter hyperintensity, and those are lesions indicated of a vascular dysfunction of the brain. So we recently did a study where we wanted to look more into the migraine-stroke relationship, and we wanted to look also at the underlying female-specific risk factors. And thus we looked also for the difference in etiology in women with stroke with and without migraine. And we also compared the white matter hyperintensities in stroke with migraine and migraine. But to come to this, we didn't show any further white matter hyperintensities in women with stroke with migraine compared to those with only stroke, so that's good news. But we also wanted to look at the etiology, and there we found an interesting finding, which is on the right. So the right side is the most important of this picture. And what we actually found is those women with stroke without migraine, they had a higher occurrence of smoking. So smoking was the most important risk factor in those women. Whereas in migraine women who had a stroke, there was less smoking. So the important implication is that if you have a stroke and you see a stroke patient, female patient, as a neurologist or general practitioner who is not smoking, then it's very likely that migraine might be one of the risk factors making this woman more prone for strokes. So there was no risk difference in the white matter hypertensities itself, but we showed that migraine is an important risk factor for stroke. So women with stroke without migraine are more frequently smokers, and women with stroke and migraine have more strokes of undetermined origin, which is more a technical issue. And I think the last sentence is more important. Physicians are advised to obtain detailed migraine histories from women diagnosed with ischemic stroke. So we should be very careful when we have a migraine women to also carefully monitor their cardiovascular risks. So I will end with this general recommendations. One of them, I think, is that we as neurologists need to work together with gynecologists. You as patients have a lot of questions on hormones, on menstrual complaints, on perimenopausal complaints. We also know that migraine women are more prone to have, for instance, difficulties during pregnancy, like high blood pressure. So we have to work together, and you also as patients, you have to be aware that you need to ask both neurologists and gynecologists, but also the general practitioner, to be aware of your migraine and also to be aware of this as a risk factor for strokes. We really need to perform clinical trials, and we want studies to show what kind of hormonal treatments are best to treat menstrual migraine-related attacks. And we also need to study the underlying pathological mechanisms. This is to show you my daughter again. So after this student period where I was really afraid that her migraine would deteriorate, she now finally is elder. She's now 25, and she actually also joined me with the last Migraine Trust International Symposium. And here she's presenting one of the posters that she worked on with me and the anesthesiology department at Leiden University. So you can see that even for young women, they will overcome their migraine attacks, or they will even become a potential migraine researcher if you treat them with efficient medications. And I would like to thank my study team. So I think it's really important. You can see on above the 5 women, of which I'm one of them, who are in the WATS study team. And I think and together we do a lot of good research to get more insight in the influence of hormones. And below you see the Leiden headache group in general. And you can also see our websites where you can find more information. If you want to contact me, you can always send an email to me. And with that, I would like to thank you for your attention. And I will stop sharing. So.
Thank you, Gisela. That was great. Covered a lot of really interesting information there. So thank you for that. I know we've got quite a few questions already on Slido, so I'm going to pass straight over to Oscar. So hopefully we can get through some of those. Thank you.
Thanks, Pippa, and yeah, thank you, Gisela. Thanks, everyone. Yeah, lots of questions come through. So one of the most common questions that comes through is actually about that post-menopause and post-perimenopausal phase, where quite a few people have shared that actually they were expecting them to get better, but actually they've continued or they've got worse, and they're asking sort of why that might be, and whether hormonal treatments may still help them, and if not, what other treatments you may recommend if that migraine continues post-menopausal.
Yeah, I think it's an excellent question. I've learned from my clinical practice that I never say to my patients anymore that it will resolve after your menopause, because it's in some of them it's not the case. So and with that they get really disappointed, and they come back to me and they say, now I'm already 70 years of age and I still have my migraine attacks. I think it's good to know that if you're really what we call postmenopausal, so you don't have your menstruation periods anymore, we know that your hormonal levels will stabilize. And with that, it's not hormonal fluctuations that will likely provoke your attacks. And then I think other factors are more likely to provoke your attacks. One, and most importantly, I think if you still have migraine attacks in your postmenopausal life, it's likely very genetically determined. So you should be aware that probably your mother had migraine, or your father had migraine, or your grandmother had migraine. I think those that remain at an elderly age, those are the people who have a huge genetic load within their DNA. And probably I'm one of them as well. So that's why I transmitted my migraine to my daughter. And I think also if you have migraine with aura in your family, then it's also more likely that it's more genetically determined. So, and it's less likely that you will get rid of your migraine, because it's just your genetic DNA that makes you more prone for this type of attacks. And with that, I don't think hormonal treatment will be helpful for you at all. Because I don't think it's the level itself of the estrogen or the progesterone, it's just the fluctuations that makes you more prone. And if you're in the postmenopause stage, then it just dropped a bit, but it's still stable. So it doesn't help if you stabilize it or if you increase it. I don't think that will be helpful for your migraine attack. So you need another type of approach. And I think we are quite happy with a new type of preventive medications which target CGRP, as you know. So the monoclonal antibodies against CGRP, or the GPANs against CGRP. And I think that kind of medication are needed for those who are at an elderly age and still have migraine attacks. I think you need that kind of preventive medication for your attacks. Yeah.
Yeah, ideally, yes. We have certain pathways in this country, unfortunately, but yeah, I agree. So
I
at this
know.
stage,
Yeah, we're
yeah,
the same. It's terrible. I think,
yeah,
to say something about that, I think it's terrible that we're still not able to convince, as patient organizations, but also as doctor organizations, to convince those people who are in the government and in the insurance companies that there's a huge need for a good preventive medication of migraine, and that's worthwhile. Because if we have all the migraine patients up and running, and they're able to work and to provide and to be social and take part in the society, I think the amount of cost of the medication is 10% of what the productivity of all these patients would be. So I think we really should strive to get better reimbursement for this kind of treatments.
thank you. Yeah. Right, second question for you. So someone's asked, can you advise on the best way to go about getting a diagnosis or be able to tell if their migraine's being caused by hormones?
Yeah, so I've learned that if you ask patients, that they cannot remember whether it's related. So you can only know whether you have menstrual migraine if you keep a diary. And you can do it in a very simplistic way. Just keep your own diary, indicating your menstruation period and following up whether you had migraine attacks. But we are now so used to our electronic diary. With that, it's very easy for us. We can immediately see, and also our patients can immediately see whether it's menstrual related. But if you don't have this opportunity, I would suggest that you just put on your whatever device you have, just indicate when did you have your menstrual period, and follow up your migraine attacks, and then you can see whether there is a relation. And if you have 2 out of 3 menstrual cycles, you have a menstrual migraine attack, then I think you have menstrual migraine. You are menstrual migraine patients. In general, I would say we know that 2 out of 3 women will have menstrual related attacks. So it's the majority of women. It's very hard actually to find a person who has still menstruation in which the attacks are not related to the menstrual period. It's really hard to find those persons. So in general, I would say it's very likely that all women with migraine, almost all, have these menstrual related attacks.
Thank you. Yeah, a good reminder. And yeah, I think it's a good reminder as well that how important a diary keeping can be. And yeah, great. Thank you. So we talked about treatments and the pill, HRT, estrogen can be useful, but for some people they actually find it can make their migraine worse. So someone said that the pill can cause their aura to get worse. Do we know why this is? Why for some people it actually can trigger migraine?
Yeah, so I know that for migraine with aura, it probably triggers your attacks. And my daughter is one of the examples of that. So she had, she started with oral contraceptives when she was quite young, I think 16 or something like that. And actually, after 1 month, she had her first migraine with aura attack. So she never had migraines, but when she was on the oral contraceptives, she developed migraine with aura. So I was, of course, as I'm a neurologist, I was aware of this relationship. So that's why we stopped the contraceptive. And we re-challenged her after 1 or 2 years to look whether it still would be provocative for her aura attacks, and it actually did. So when she is on this hormonal treatment, she gets a storm of auras, and that's what's quite often said by women who have migraine with aura. So even besides the fact that if you have migraine with aura and your majority of attacks is migraine with aura, and you have to discuss with these women whether oral contraceptive is wise because of the stroke risk. But apart from that, many of these women experience that hormonal treatment will provoke their aura attacks. Whereas in women who have only migraine without oral attacks, most of these women, they react positive on the oral contraceptives, but we're not sure. That's why we're doing this trial, because we think this is what people tell us, but there is no clear proof of this, and there are only very tiny small studies. So it could well be that indeed there are women who have a positive experience, will have a positive experience with this kind of treatments, whereas others will have a negative experience. And that's why we're doing this WAT trial currently.
Thank you. In those occurrences then where people find that the hormonal treatments do trigger and make their attacks worse, what would be the next course of treatment you'd recommend for them to explore?
Well, I think first of all, you have. I think we need to be aware that there are many different hormonal treatments. So my first question would be, what kind of hormonal treatment are you using? So some of the women with migraine, they use the Migraine intrauterine device, and it's only with a bit small amount of progesterone, and sometimes this can be helpful as contraceptive without provoking migraine attacks. Although I also have some women who actually this provoked auras in them. So still you have to look on an individual level what's doing it with a woman. But if you really are thinking that hormonal treatment will provoke your attacks, I think you should stop it, of course. And then you have to use the common prophylactics as we all will be using also in men. So yeah. Some
Perfect.
small
Thank
remark
you.
also on the acute treatment in all of the perimenstrual attacks, because I showed you that there's often a recurrence of attacks, and I'm not sure how it's in England, but in Holland, in the guideline for our general practitioners, it's indicated that they should start with sumatriptan 50 milligram. So that's our GPs in Holland, they start with only 50 milligram of sumatriptan. And these GPs are unaware of the fact that this might provoke more recurrences. So they stick to the 50 milligram, and then they do not increase this dosage. So I would strongly recommend to each of all the patients that are listening now, if you have the experience that your triptan or acute medication, it works, but there is always a relapse of a recurrence of your migraine attacks during your menstrual period, go back to your neurologist or GP and ask for another treatment, or increase your treatment, or add a long-acting NSAID during the evening to prevent this recurrence. Many doctors are unaware of this phenomenon of recurrence, and this provokes this medication overuse headache. So that's really important. You should be aware of that, and most doctors are unaware of this phenomenon as well.
Absolutely. Thank you. So someone said that they get monthly menstrual migraine, but they also get a second migraine halfway through their cycle, and they're asking if there's a hormonal explanation for this pattern, or whether it may be unrelated and they perhaps have mixed migraine and it's other triggers contributing
Yeah,
towards it.
yeah, yeah. Yeah, we have submitted a paper on this because many patients, they claim that they have this peak during the menstruation period, but also during the ovulation in the middle of the cycle. So we actually were able to investigate it, and I can already tell you there's no peak incidence of your migraine during this ovulation period. We didn't find it. So I think it's a coincidence, and you can only find this coincidence if you have this time-locked e-diaries. Then you can actually look how often your migraine occurs. And this is, I think, a bit the same as me with my daughter going to Leiden to study, and I was saying to her, well, you're sleep deprived, that's why you have your migraine attacks, you drink too much alcohol. But when we looked in her diary, we could actually see that when she was on vacation with us and she was sleeping well, she wasn't drinking anything, the frequency of attacks was still the same. And we also looked, for instance, whether she was stressed when she had exams or something, and there was no relationship. So that's why I'm really eager to study the coming years to look at trigger factors in general. Also, like look at personalized trigger factors. So if you have the idea as a patient, this is a trigger for me, you can just record whether you have this trigger factor each day, and then you can look whether there is a relationship with your migraine attacks. And this is the way I think we should approach this, to look whether it's actually a true trigger or whether it's a coincidence.
That's, yeah, really interesting. I'd be interested in reading that research. It sounds
Yeah.
really interesting. And yeah, I think, yeah, it's a interesting indication that there could be other figures going on as well. And like you said, since
Yeah.
there's always other stuff going on. Thank you. So thinking about younger people now then, so kind of thinking about hormones in younger people. So someone said that their 9-year-old has started having migraine. Um, and could hormones be related at this age? And they've also asked, is there anything they can do to prevent, thinking about their age as well in terms of treatments, but is there anything they can do if hormones are related for their age as well?
Yeah. Well, I think it's quite complex. So, for instance, if you have a young child who has migraine, there are, I think the most important factor why you have at a younger age your migraine is due to your genetic architecture. So, it's likely that in your family it's already occurring. And at the same time, it's also likely that as your mother or father has migraine, the recognition of your migraine is more easier. So to talk about me, I only recognized my migraine attacks when I was already a medical student, because my mother previously labeled this as tension type headache or whatever. I was stressed. So my migraine when I was young was not recognized by my mother or father as migraine attacks, and it was also not recognized by me. So the fact that you have migraine yourself, it is more likely that you will recognize these type of attacks in your children at a younger age. And at the same time, it's also they're more genetically prone, so there's also likely why they have this at a younger age. At the same time, we know that the age of onset of your puberty is dropping down with all the generations. So young children, especially young females, are getting into their puberty more at a younger age than 30, 40 years ago. So I think one of the questions would be, is there already a sign of these young women to come in puberty? Then it might be that it's also hormonal related. If not, then it's probably just the genetic predisposition why this young child will have migraine attacks.
Thank you. That's very helpful. So probably got time to squeeze in 2 more questions and then I will let you go. So the first one is looking at symptoms of perimenopause and menopause and why they might trigger a migraine. So someone said that when they get hot flushes, they tend to get migraine attacks. Why is that? Is there a reason for that particularly? Is there something they can do that might help when they have a hot flush that might help their migraine?
Yeah, we know there's a relationship between hot flushes and migraine. So we know that women with migraine are more likely to experience hot flushes during the perimenopausal period and thereafter. But we are totally unaware of this relationship. So there hasn't been any research on this. And this is one of the things I think we should work together with gynecologists, because I think migraine women, they go with their hot flushes to the gynecologist, and he or she is going to treat them for their hot flushes or perimenopausal complaints. Whereas when they come to me, I only ask about the migraine, and I don't ask about hot flushes or other perimenopausal complaints. That's why I think these women deserve to have a combined treatment and a combination of the view of a neurologist and also a gynecologist. So it's intriguing. I think I know it's true. I'm not aware that having hot flushes provokes a migraine attack. I think it's more likely that the hot flushes are triggered by these fluctuations, and these same fluctuations also provoke your migraine attacks. So it's the fluctuation of the hormones that provoke your migraine attack, but not the hot flushes per se. Yeah.
Okay, perfect. Thank you. Really interesting again. And the last thing is, so this has been a really interactive group. It sparked such conversation and debate in the chat, which I always love to see, but people have been sharing their experiences and stories. And there was a big debate. So we're going a tiny bit off topic, but there's a big debate about whether food was a trigger for migraine attacks.
Yeah.
And neurologists seem to disagree, and people were really debating it. So they wanted to know your opinion.
No, I'm really intrigued by the food, and I can say to you it's really difficult. So we are trying to do in our trigger studies also to ask people what did they eat, but it's really tough to know what you're eating. So now we're just asking, are there certain foods that you think that provokes your attacks? This is really tough to investigate, to be honest. And one of the things that we try to investigate is how do you call it? If it's not sugar, but you have this alternative sweet, how it's called, sugar-free. So we
I know exactly what the kind of sweetener type stuff. I know exactly what you're trying to
so
say.
it's sugar-free, but it's an alternative. Yeah,
Mm.
Hazel was trying to say something, but I don't hear you what you say. But you know what I mean. So we ask it in our diary, and people don't know. So we are completely unaware of what we are eating all day, unless you're really looking it all up. So we're trying to look at the relationship for these alternative sweets that are not sugar, whether it provokes their migraine attack, and it's already, I know it's rubbish data because people are unaware. So even my daughter, she filled out this diary, and she said after a month, she said to me, "Oh, I forgot that I drink Cola Zero. So there is sweet in it, but no sugar. But I didn't indicate it whether I drink my Cola Light or not." So it's really tough to do this food investigation. But I think if we have new possibilities to combine, for instance, your diary of your food schedule and migraine, I think it would be great to combine this also on a personal level, whether you can see whether there's a relationship or not. Yeah.
Perfect. And exactly exemplifies why it's so complex as an answer.
Yeah.
Thank you so much, Gisela. I will pass you back to Pippa now, but that's been great. Thanks for answering all my questions.